Welcome to the webinar entitled Willebrand Disease Diagnosing and Treatment. My name is Rich Pizzillo, and I'm the Executive Director of the New England Hemophilia Association. During NEHA's inaugural VWD retreat on Saturday, July 28th, Dr. Salley Pels from the Yale Hemostasis Center provided the keynote presentation. Dr. Pels will be giving this informational presentation this evening for those who were not able to attend the retreat and for those who want to listen to it again. This webinar will provide you with a fundamental understanding of VWD, how it works in the body, and the products used to manage the condition, as well as a deeper dive into the more advanced nuances. This webinar will be recorded in its entirety and then placed on NEHA's YouTube channel. Everyone is currently muted. To ask a question, simply use the question box in the GoToWebinar control panel to the right of your screen. At the end of the presentation, we'll answer as many questions as we can. No personal medical advice will be offered during this webinar. If you have questions regarding your care, please contact your medical provider. Without further ado, I'm going to introduce Dr. Salley Pels. Dr. Pels is the Assistant Professor of Pediatrics, Hematology, Oncology at Yale Medical School and the co-director of the Yale Hemostasis Center. She received her medical degree at the University of Vermont and did her residency and fellowship at the Yale University, where she currently is employed. Dr. Pels was also the recipient of the National Hemophilia Foundation Baxter Clinical Fellowship Award, where she spent an additional year of training in hemostasis specifically. Dr. Pels has a particular interest in caring for patients and families affected by bleeding and clotting disorders with a focus on quality improvement. She is on the board of FISNA and the Hemophilia Alliance and Quality Improvement Working Group for Athens. Dr. Pels, I'm going to now turn it over to you.
Thank you, Rich. And there we go. And thank you to NEHA for inviting me to present on the diagnosis and treatment of von Willebrand disease. For the sake of time, I'm going to jump right in and just review the agenda for tonight. I'll first start by reviewing a brief history of von Willebrand disease, the initial description, and then some of the early landmark events within the diagnosis and treatment of the condition. Then we'll go into getting the diagnosis right, the ins and outs of the laboratory, and some about the genetic testing that's available to us at this time. Moving on to common symptoms and their management, and then what does the future hold. This first described by Dr. von Willebrand in a paper that was published in 1926, and it described the family of a young woman, Hordis, from the Åland Islands in Finland. The family that was described was extensive, and as you can see, this graphic shows one of the original family trees that was published in the literature with this family. But the young woman that was originally described, as I said, is actually right down here, a child who started to have symptoms at about age 2 or so. But it was the family was somewhat different from other families that had been previously described with another known bleeding disorder, hemophilia, in that children, both boys and girls, seemed to be severely affected, and in many cases the girls were more affected by the bleeding symptoms in this condition. And so it seemed that the inheritance pattern was definitely different from hemophilia, and so it was termed pseudo-hemophilia. Really from then on, it wasn't really for about 30 years until they really described the von Willebrand protein as a known entity or a known clotting protein, and it was named after the original Dr. von Willebrand in 1957. As you can see on the timeline here, the advances in understanding von Willebrand disease and the care of von Willebrand disease has been going on since then. The original treatments really that were offered were back in the 1960s and 70s, with cryoprecipitate, and then fortunately in 1977, Dr. Pierre-Minucci had understood that DDVP could be useful for many patients with von Willebrand's as well. Hum8P was one of the first factor products that was specifically for von Willebrand disease and was approved in 1981. And then moving right along, the von Willebrand factor gene was cloned in 1985, but it took many decades before scientists were able to really recreate and reproduce the protein in a cell line to create the recombinant product that we know as von Willebrand today, which was only approved several years ago. So von Willebrand disease doesn't just come from Finland and the Åland Islands. It's actually a very common bleeding disorder. As many of you know, it really is the most common bleeding disorder that your friends have never heard of. There are some large population studies that have detected when testing is done that up to 1% of the population really have low von Willebrand levels, and many of them in the diagnostic range. I'll go a little bit later into the different subtypes, but just briefly, type 1 von Willebrand disease, which is a mild to moderate reduction in the von Willebrand protein, typically is the most common, with 75% to 80% of people with von Willebrand disease having that subtype. Patients get diagnosed in a number of different ways, and really we predominantly think of patients who have symptoms, but of course as we age, the types of symptoms that may develop in an adolescent or a young adult are certainly different than something that may happen in an infant. And so there are certainly children who do get diagnosed with this condition even prior to any significant symptoms developing. And then rarely do we have patients who come to us after having abnormal labs on screening, but have neither a family history or bleeding symptoms to speak of at that point. So the von Willebrand factor, what is it exactly? So it's a large protein that's found in a number of different places in the body, but predominantly where we bleed. So circulating within the blood, but also found in storage pools within the cells making up the blood vessel wall, as well as in platelets, which are the blood clotting cells. This is a large protein that binds to itself upon itself in what we call multimers, in multiple repeated proteins that link together to each other to more effectively assist in blood coagulation or blood clotting. So how it works more specifically is that it's really we think of it as the glue that binds different components of the blood clotting system together to really firm up a blood clot. So I just have can you see, hopefully you can see my arrow here, but this diagram is a picture of just the blood vessel and the blood vessel wall, the cells that make up the blood vessels, as well as the von Willebrand factor protein found in each of these locations. When a cut is made in the blood vessel wall and bleeding starts to happen, the von Willebrand protein really goes to that site and helps to recruit the blood platelets, which activate and assist with bringing together more of the blood clotting proteins as well. The von Willebrand factor also binds not only the platelets, but also collagen fibers here in the purple, which are found in the lining of the blood vessel as well, which just firm up that clot again. And the von Willebrand protein also brings in another important blood clotting factor, or factor 8, that protein. When patients are deficient in that, we call that hemophilia A. So diagnosing von Willebrand's is actually probably one of the most complicated and complex things that a hematologist can do. But the basic von Willebrand panel typically includes the von Willebrand factor antigen, which is the protein level, the ristocetin cofactor, which is the function level, and the factor VIII. As I had said, factor VIII is a separate separate coagulation protein, but it is carried in the circulation by von Willebrand factor. And so when there is insufficient amount of the von Willebrand factor, or it's not functioning properly, the factor VIII levels can also be affected. Other tests that I'll talk about in a couple slides that we use to diagnose von Willebrand disease include the multivariate analysis, the platelet count, and the blood type as well. So when we are trying to decide what type of von Willebrand disease a patient has, as I said, we use that basic panel to understand what the levels are. And as I said previously, type 1 von Willebrand disease is typically associated with a moderate to mild to moderate reduction in the protein level itself. And so the antigen, which is again that protein level, and the ristocetin, the functional assay or the test of how this protein works in the system, should both be low at the same level. We use the ratio of those two numbers to really delineate the type 2 defects or the defects in the function of the protein itself. For patients with type 1, they also, as I said, typically or often will have a slightly low or low normal factor VIII level. Patients with type 3 von Willebrand disease really have almost no detectable von Willebrand factor, and so both the factor level and the activity level should be nearly undetectable. Patients with very low levels of the von Willebrand protein, again, will also have a significantly shortened lifespan of the factor VIII, and so that level is often quite low and sometimes and frequently less than 10%. Now, I made it sound very easy trying to diagnose patients that you just look at the number, see that it's low. But there are a number of challenges when it comes to the testing itself. The blood draw and the way that the environment in which the labs are taken do really affect the levels themselves. We often will see borderline lab values for patients who have blood type O. So the common blood types or major blood types being A, B, and O. Patients who are blood type O tend to have a low normal von Willebrand panel, or von Willebrand levels, even if they don't have the disease. Sometimes when blood is drawn, if it's drawn off-site at a distance from where the lab test will be run, if the sample does take some time or there's a delay, some of the proteins within the blood can degrade and make it difficult to really get an accurate picture on the lab test. So there are frequently times when we have levels that are perhaps somewhat lower than they really should be, sort of giving us a false low reading on those tests. However, more often than not, hematologists are really faced with borderline values that are falsely high or falsely elevated to some extent, levels that are in the borderline range. But if we have a patient who's in front of us who's really displaying symptoms and we're worried that they have the condition, we have to consider that there are other stressors on the body that may temporarily increase those levels, making the testing somewhat challenging. Those stressors on the body can literally just be stress. The stress of the blood draw, anxiety. I'm a pediatric hematologist, so I take care of mostly children, and children don't like getting their blood drawn. Really, adults don't like getting their blood drawn, and so that even just that stress can, as I said, temporarily increase the von Willebrand protein levels. Other stressors like the common cold or exercise, and then hormones are another big category. Estrogen, which is in high levels not only in pregnancy but also can be elevated by a young woman or any woman using hormones to control her menstrual cycle, you may see some fluctuations or some abnormal or slightly higher numbers depending on where a woman is in her cycle. And then lastly, the more times we have to go and attempt the blood draw, as I had mentioned, the von Willebrand protein is found in pockets of stored within the lining of the blood vessel wall. So imagine you have a needle that you're trying to draw blood from a blood vessel, and each time you go in, you're releasing more and more von Willebrand protein, causing that high, the false elevation in those levels. So as you can see, there are quite a few things that really affect our patients' levels that we don't always have complete control over. Apologies, I went back and forth on those slides. I'm going to skip over the slides we just reviewed and go on to the next slide. So that was type 1 and type 3. As I said, those were what we call quantitative defects, or really a defect in the amount of the protein, how much is circulating and available to help assist in making a clot. The other subtype that I will describe now is the type 2 defects, and there are a number of different type 2 defects, but broadly these are functional defects where the von Willebrand protein itself just isn't quite working the way it's supposed to, and there are a number of different ways in which or functions that might be abnormal depending on which subtype. Really, to diagnose the type 2 defects, not only do you need the typical von Willebrand panel, those labs that I had already described, but you need something called the multimeric analysis. There are a couple other tests that I'll briefly review as well, but for simplicity's sake, we'll start with primarily the multimer analysis and a description of what these values mean. So the multimeric analysis itself is really a test that allows us to understand how well the von Willebrand protein really sticks to itself, and that can give us a clue as far as what kind of defect there might be within the protein. The von Willebrand protein normally clumps together in what we call low molecular weight, intermediate, or high molecular weight multimers. The multimer analysis test itself, when it's run in the lab, actually looks like this picture. The samples that of blood that go into a gel, and the protein is forced against an electric current, which allows certain different low, intermediate, and high molecular weight multimers travel through like a sieve. The sieve analogy is one that only goes so far, but I really like to understand it in a slightly different way, which is if you picture the multimers as groups of children running through the forest, you have a large group of children that really is much slower going through the forest, a slightly smaller group that goes a little bit faster, and then two children on their own can really get through at a pretty good clip. And so the smaller multimers, you can see, run from top to bottom a lot faster than the large ones. There are defects in how as I said, in how the protein sticks to itself that you can really elucidate using this test. Those subtypes that we talk about are really classified as 2A, M, B, or N, and I'll go through those in more detail in the next slide. So type 2A and type 2M, the first and the third column in this chart, are some of the most similar, they're most similar to each other. Those are two type 2 defects that are quite similar. They are abnormalities in they are defects in how the von Willebrand protein binds to the platelets, but also the main distinction is that patients with type 2A typically have a loss or a lack of the high molecular weight multimers, whereas the patients with type 2M do not. Type 2B patients have a very specific defect in which actually the von Willebrand protein has enhanced binding to the platelets or the blood clotting cells, which typically results as well, or occasionally results as well, in a loss of these multimers because the large proteinaceous glob, so to speak, of von Willebrand factor is really bound to the platelet and is not detected in the specimen when the test is being done. These patients also will typically have a borderline or low number of platelets circulating because of the large amount of von Willebrand protein that's on the surface of these platelets. They have a shortened lifespan. They don't last in the bloodstream as long, and so typically they have a slightly lower level. And then the last subtype of type 2 von Willebrand that we'll talk about is type 2N. This is actually a defect in the binding pocket for factor VIII. And so while you may, or patients may have a slightly reduced von Willebrand protein and activity level, the factor VIII level will be quite reduced in an unusual fashion compared to the remainder of those levels. One thing I had mentioned previously but didn't really go through, and I do want to point out as well, is that for the type 2 defects, type 2A, B, and M, compared to the protein level, the antigen, the ristocetin or the functionality of the protein is significantly reduced. So you will see that lower ratio of the ristocetin to the antigen in these subtypes. As I said, there are the descriptions that I've put in the tables and the numbers or sort of the ratios that I've described is a simple, as simple as it can be, description of how we make this diagnosis. We sometimes do have a bit of a mixed picture situation where it could be one or another of these subtypes, and there are a few other tests that hematologists will use to try to distinguish those subtypes. That includes the RIPA, which is the ristocetin-induced platelet aggregation, or really looking at how the von Willebrand protein, how much of it binds to the platelets, how quickly and how effectively, but also the second test I have listed here, which is the factor VIII binding assay. These can sometimes be helpful, but some of these tests, I must say, are not run at most centers and often require a send out and are sometimes challenging to get. And so for many of our patients, one of the other ways that we can really understand the subtypes is doing something called the DDAVP challenge. I'll talk more about DDAVP later, and as I've already stated, and as many of you know, DDAVP is one of the mainstays of treatment, is a medication that helps to enhance the body's release of stored von Willebrand protein, but evaluating a patient's response to this medication is not only useful in understanding what medications or what treatments might be effective for the individual, but also can give us a little bit of a clue into the subtype and the diagnosis. Lastly, genetic testing is something that we often are asked by our patients and families, what is available and what can we do. There are certain subtypes of von Willebrand disease that have genetic testing available to us, particularly type 2N von Willebrand disease. However, there is no standard or one gene test one test that we can do that really there's not one mutation or one change in the von Willebrand protein gene that leads to von Willebrand disease. It's actually it's many. beyond the fact that deciding what to test for and how, as I said, the availability of many of these tests is not always, within your center, and unfortunately, we always are also forced to consider the cost and what can be done, given the how challenging these tests can be. As I said, there are many known mutations that lead to both type 1, type 2, and type 3 von Willebrand disease. As you can see in these schematics, it's more than can easily be done with a one-step blood draw. That being said, the understanding of von Willebrand disease goes back many decades and started out with understanding the inheritance pattern and how it was different from hemophilia. Hemophilia being an X-linked disease, meaning that it's carried in the maternal bloodline on the X chromosome, which determines the sex of the individual. However, the von Willebrand factor gene is not on one of the sex chromosomes, not on an X or a Y, and the mutations or the changes in the gene that lead to disease can actually be inherited either in a dominant fashion or a recessive fashion in certain cases. Patients with type 1 disease are, putting it simply, felt to be to have a dominant mutation, whereas type 3 patients have, in some cases, 2 type 1 dominant mutations leading to a recessive form, however, really just having essentially 2 type 1 mutations leading to the disease. When we talk about dominant and recessive, just to bring everybody up to the same place, up to speed, a dominant mutation is one where if an individual has the condition, there's an opportunity, a 50-50 chance that any child will either be affected or unaffected. Those who are unaffected do not carry the condition, and those who are affected, of course, can pass it on to their children. Patients who have a recessive condition, on the other hand, can either give one copy of that mutation or that gene change to one of their children when they can be a carrier. However, if 2 carriers get together and have a child, there is a 1 in 4 chance that their child could be affected by that condition. So beyond getting the genetics and beyond the laboratory testing, before all that, we have patients who have symptoms. The symptoms of von Willebrand disease are varied, but most commonly, patients who come to us have noticed a long history of easy bruising, frequent or more accurately prolonged nosebleeds, dental bleeding, either bleeding at home with brushing teeth or often with dental cleanings, intestinal bleeding, and then significant menstrual bleeding or surgical related. The most common bleeding symptoms that we see in patients with von Willebrand disease tend to be what we call the mucocutaneous. Muco meaning the mucous membranes or the nose or the reproductive tract, which often have bleeding symptoms even in those who don't have bleeding conditions. And then from there, the dental and easy bruising are common. For patients with von Willebrand disease, the more classic symptom of a joint bleed that we see for those with severe hemophilia is not very typical of your patients with type 1 or type 2 disease, but is certainly seen in patients with severe or type 3 disease. And is important to keep in mind when we are talking about the treatment and the kinds of treatments that are available to those patients. So when we talk about treatments, and obviously first and foremost, we want to target the defect or the deficiency, which is the von Willebrand factor. But we also can target either other areas of hemostasis, so other areas of blood clotting, as well as other ways to manage specific symptoms. DDAVP works or is administered, either into the nose directly using a nasal spray or by IV. It works, as I had mentioned previously, to it causes the release of the von Willebrand protein from the cells that line the blood vessels, releasing that into circulation and increasing the levels of the von Willebrand protein itself. A secondary effect of DDAVP is actually enhanced platelet activity, which is a great bonus, and one of the reasons that this medication is not only used for patients with von Willebrand disease, but a number of other bleeding conditions. The next slide is a little busy, very busy, but it serves to really describe that there are different patterns of response to the DDAVP medication that, as I had previously stated, that tell us or give us a clue as to what subtype of von Willebrand a patient might have, but I won't go and belabor the point with going through every single point on this slide, except to say that some patients do have varying responses to DDAVP, and it's important to keep that in mind, which is why patients, before they are prescribed this medication, go through the challenge test. As I said, the response will vary not only based on your von Willebrand diagnosis or subtype, but sometimes people do have a shortened response to DDAVP, and it may not be that they just have a different subtype, but that their bodies really just chew through the von Willebrand protein a lot faster than another individual's. This can happen because of different processing mechanism within the body, but also it happens actually in children as opposed to adults. One of the bigger drawbacks to DDAVP, there are a number of side effects that I haven't mentioned yet, but when we give the DDAVP, as I had said, it causes a release in the storage pool of from the blood cells that line the blood vessel. But once you release that stored protein, your body has to take time to replenish those stores. And so repeated dosing really doesn't necessarily, at least in a succession within a short period of time, doesn't really result in the same kind of effect. So repeated dosing is generally not recommended for that reason. The other reason is that it has a secondary effect on the kidneys. And it changes how your body holds on to salts and water. And so we do have to be careful. Usually your hematologist will tell you to be careful with the amount of fluid that you take in for the 24 hours after using this medication. In addition to DDAVP, the other main way that we increase the von Willebrand protein is by giving the protein product itself. I had mentioned Humate, which is one of the first plasma-derived von Willebrand protein products. There are a number of ones on the market, including Willate and Alphanate, and they differ a little bit in how they're processed and a little bit in the ratio of the von Willebrand factor to factor 8 within the product. But they all have a very similar effect and will raise the von Willebrand factor reliably in patients who use it. The newer product, the recombinant von Wende, is a synthetic version of the von Willebrand protein grown in a cell line, and it does not contain any appreciable factor 8, and so it is frequently used for patients who have severe disease or in certain other situations where you do want to be careful with the amount of factor 8 you're infusing. It does seem to have a bit of a longer half-life than the plasma-derived products, but everyone is different, and individuals should really use what works for them and talk to their hematologist directly about the whys and of which one and the decision to use which medication. The side effects with these medications are relatively minimal. Certainly, overdosing or repeated high doses of these medications, because they normalize what's deficient, could potentially put someone at risk for a clot, but that's not something that, with close monitoring and conjunction with your hematologist should not, dosing in conjunction with a hematologist experienced in von Willebrand care, this is not something that should be of great concern. Another question that we sometimes get is the risk of something called an inhibitor or an antibody to these products, and it's something that is very rare, but can happen in those, particularly the patients with type 3 disease who don't make any of the von Willebrand protein. When that individual's immune system sees the von Willebrand factor protein or product as really a foreign substance, it may mount a reaction. Again, that's a very rare event and not necessarily a reason to avoid these medications when needed. As I said, the mainstay of treatment for von Willebrand disease is really targeting the von Willebrand factor products or the factor levels. However, we do target other aspects of hemostasis with medications in the class that we call antifibrinolytics. These medications, primarily Amicar and Listata are the brand names. They work really well for mucosal bleeding because our mucous membranes make enzymes shown in this diagram as scissors that actually break down clot, and these medications are used to prevent the activity of those enzymes. Now, this works to some extent, although for significant or severe bleeding, anyone with von Willebrand disease really does need to first raise the von Willebrand factor levels, then potentially, once the clot is made, stabilize that with one of these agents, as I said, Amicar or Listata. So then specific symptoms. There are a number of symptoms that I have mentioned previously that patients with von Willebrand disease typically experience: nosebleeds or epistaxis, oral bleeding, heavy menstrual bleeding or menorrhagia, and then needing treatment in the midst of pregnancy, delivery, and surgery. So, the typical first aid that we advise our patients for nosebleeds are really the same thing that most people will hear from, a child from their school nurse, which is apply pressure. Ice can be useful as well. The use of moisturization, saline, and Vaseline are typically advised to really prevent the bleeding in the first place, because the medications that we use in reaction to the bleeding symptoms are really not very well designed to prevent them in the first place. And so really keeping a moist nasal mucosa or the mucous membranes in the nose moist can go a long way towards preventing the bleeding in the first place. However, in the event that a bleeding event does happen, we usually advise treatment with their standard medications if the bleeding is lasting for a long time. Similarly, for oral bleeding, really the same kinds of recommendations are made for those symptoms and really treatment if the bleeding is prolonged. Menorrhagia or heavy periods, heavy menstrual bleeding is certainly an important symptom to control for a number of reasons. Obviously, girls and young and women who have a bleeding tendency are going to typically bleed significantly more than those who do not, but ongoing monthly bleeding severe bleeding can lead to significant anemia, which results in fatigue, but also difficulty with attendance at school or work, and can cause quite a lot of distress in our patients. So in addition to our typical medications that we use targeting the bleeding symptoms, one of the other things that we often will recommend to girls, and as I said, and young women, or any woman who's having these kinds of bleeding symptoms, is that hormonal control can actually be quite effective at reducing a lot of these symptoms. Typically used combined oral contraceptive pills, but some of our patients do find a lot of benefit from things like an IUD or intrauterine device pictured here. In the past, surgical control of bleeding was much more common, meaning hysterectomy or removal of the uterus. It's really not recommended, especially for young women who intend to have children. So that is certainly, unfortunately, many patients decades ago probably had that and could have potentially avoided it with the use of hormonal methods. But at the time, that was really all that was available to them. So as I said, the primary prevention of menstrual periods is really hormonal method, or heavy menstrual periods is hormonal methods. And then secondary prevention, we do use our DDAVP and von Willebrand factor products, as well as the antifibrinolytics, to help control the bleeding, particularly if bleeding is really not even well controlled with hormonal methods. We do sometimes need to use those in conjunction. Delivery, pregnancy and delivery is a unique and special time for all of our patients and families. Pregnancy itself actually can cause quite a few changes in the blood clotting system. And for those with milder disease, particularly mild type 1 von Willebrand disease, those patients, those women will often experience an increase in the von Willebrand factor levels, particularly in the third trimester. And that's actually a normal phenomenon that doesn't only happen to women with von Willebrand disease, but happens to all women. And that's a protective mechanism to prevent hemorrhage during childbirth. And so women who have mild disease may actually, when tested, normalize their levels and not necessarily need specific help with medications during the delivery. That being said, immediately after delivery, the hormone levels that are circulating can change dramatically. And those women who had essentially normal levels at the time of delivery do need to be careful about bleeding that happens post-delivery. Some of those levels dropping can be mitigated a little bit by breastfeeding, which allows some of the additional hormone expression and boost that happens to the von Willebrand factor levels. And so we sometimes also see some protection, as I said, during the time of breastfeeding. Women with more significant or severe von Willebrand disease do need more assistance during delivery, and that's typically with the von Willebrand containing product. When it comes to the use of DDAVP during delivery, really needs to be in conjunction with the OBGYN and the anesthesia team if they're involved, because of the way that the DDAVP affects fluid levels. Women who are in the midst of delivering do get a fair amount of fluids, and we just have to be careful with that. Women who are at risk for having a child with severe disease are recommended or at least asked to consider the mode of delivery, so C-section versus a vaginal delivery, because of some of the compression that can happen in the birth canal that can sometimes lead to intracranial or bleeding within the head for children with severe disease. But that's less of a concern for children with mild or women with mild von Willebrand disease, and we don't mandate a specific mode of delivery for those children. For any boy that is born to a woman or man who potentially or who is known to have von Willebrand disease, we often will recommend and coordinate with the OBGYN that a cord blood specimen be obtained a specimen from the umbilical cord is a lot easier to get than blood directly from the child, and it can be tested and will allow us to understand if the child's levels are in a safe range for something like a circumcision, or again, if a child were to need a procedure, it would be important to know what their level is. For other surgeries outside of the delivery room, we frequently will use DDAVP for patients who are known to respond well, but sometimes you need to use von Willebrand-containing products, and depending on how that product works in that individual, and depending on the surgery and the risk of bleeding, there are different treatment schedules and protocols that are in place for those who are having surgery. Bleeding complications are really mostly the primary complication of having these conditions, or this condition, excuse me. And as I had mentioned, one of the things that we try to certainly avoid, and we need to pay attention to, particularly in our young women, but also in men and boys who are having significant bleeding symptoms, is the development of anemia, which, as I said, can lead to fatigue and difficulty with attention at school and work. As I said previously, joint disease has probably been under-recognized in patients with severe von Willebrand disease, or type 3, but is an important complication and is something to be monitored closely for. And as I said, inhibitors are quite rare, and is not something that I'm going to necessarily dive into further. So the future of von Willebrand disease. In preparing this talk and doing this talk originally a few weeks ago, it's pretty clear that sort of one of the more complicated things when it comes to von Willebrand disease, and in my everyday life, one of the most complicated things when it comes to von Willebrand disease is making sure that a patient gets quickly and accurately diagnosed. And trying to ensure that is certainly we all strive for every day. The genetic testing that I had mentioned previously, I think as time goes on and technology improves and our access to this improves, this will allow us to have more accurate understanding of an individual's disease. But there is much that we have to learn about the changes in the von Willebrand factor gene, as well as other genes that affect the von Willebrand protein as well. Just as a last couple slides, a pitch for resources. I don't think I got to this with my original presentation, but there is a lot of great information out there for patients and families in a lot of different locations, and I just wanted to point out a few of them. Many of you know about the National Hemophilia Foundation. It really is not only a foundation for individuals and families with hemophilia, but really all bleeding disorders. They have a focus and several very informative informational articles about a number of different bleeding conditions, including von Willebrand disease. Their Steps for Living is a great website that really speaks to different levels and age groups and how bleeding disorders affect individuals at different times in their lives. There is a national conference that's put out by the Arizona group, the NOW conference, which is always, I've heard wonderful things. I mean, there's always wonderful things about that. And then the Foundation for Women and Girls with Blood Disorders, obviously focusing on how these conditions affect women, because as I stated, previously, and as many of you know, the bleeding symptoms can really definitely affect young women and women of all ages, in particular as it pertains to menstrual bleeding, as well as pregnancy and delivery. And we are at my last slide. I thank you all for coming tonight and listening, and I'm happy to take any questions any of you have about von Willebrand, the diagnosis and treatment.
Fantastic. Thank you so much, Dr. Pels. That was a lot of information that you covered in a relatively short amount of time. So thank you so much for doing this. As a reminder for those that are on the webinar, if you have a question, simply go to your GoToWebinar control panel in the middle. You want to hit on the arrow caret icon where it says questions, and you can type your question in there. We will try to get to the majority of them. There's 4 right now in the queue, and I will start with the first one. If someone had or has a bad reaction to DDAVP in an IV form in the past, but it's typically unsymptomatic, would you suggest having a challenge? Would you suggest changing the other types of products if they ever need to have some sort of treatment going forward? So it sounds like DDAVP has had a bad reaction to the IV, but unsymptomatic when it's not IV. And so suggestion of changing products if they need treatment going forward.
Okay. So if I understand the question correctly, there are, as I had mentioned, the one of the things that I as a physician worry mostly about is the effects of DDAVP on the way that the body handles salt and water. And I didn't really go into this in detail, but one of the things that can happen if someone has ingested too much water after the DDAVP is that the sodium levels can drop dramatically, and that can lower a body's threshold for seizures. And so patients have developed seizures, and in extreme cases, coma, and unfortunately death. That's in very extreme cases, and that's really only if they really overdo it on the water. And so we give very strict guidelines, and so that's not something that we see at this point because of the way we manage the DDAVP. That being said, there is another minor side effect that many of our patients do, or what we consider minor side effect that they do experience, which is some facial flushing and some dizziness. Now that can certainly, the effect of that can vary widely, and while it's not dangerous, it can be very distressing for an individual, and so that may be one reason why an individual has decided that medication doesn't work well for them, or they don't want to take it. Sometimes people do experience that more with the IV form than in the nasal spray form, so that if they tolerate the nasal spray form and they've demonstrated that they can take that without significant side effects, it's reasonable to use that as an alternative. I will say, though, that most hematologists, when they test how this medicine works in a patient's body, we do use the IV medication. So if we do want to use the nasal spray for, let's say, a surgery, many of us would try to get the challenge or the testing the levels with the use of that alternative formulation. So hopefully I answered the question, but certainly if someone had a severe reaction to DDAVP and couldn't take it for any number of reasons, the alternate treatment would then be the von Willebrand containing factor products. And those are certainly reasonable, as I said, if there was an intolerability to the DDAVP.
Fantastic. Thank you so much, Dr. Pels. Here's another question that came in, and I'm going to paraphrase this. What are your thoughts for a family that has history of factor VIII on the paternal or the father-grandfather side, and the son and grandchildren have all been diagnosed with VWD with no family history? The grandfather who had the history of factor VIII did not have low VWD levels. Just kind of talking through how is that possible in terms of how hemophilia being passed on versus VWD, and is it common to have both conditions being, hereditary when someone has diagnosed hemophilia and then many family members have VWD?
So yeah, so this scenario is that let's just say the paternal grandfather has a son. The grandfather has hemophilia. He can really only pass the factor VIII gene on his X chromosome to his girls. So if he has a boy, he's giving his Y chromosome, and the young man's mother is where he's getting his factor VIII gene from. And so that should be normal. Thus, there's really no chance that that grandfather can pass his own hemophilia to his son. But it just so happens that this young man himself and then his children or child is diagnosed with von Willebrand disease. Another genetic inherited disease that, as I had mentioned early on, is the most common bleeding disorder that we know when we test large populations. It is very common, and as you also could see, there are innumerable mutations that lead to von Willebrand disease. So it's possible that either just so happens the young man's mother, so the grandmother, unbeknownst to her, has von Willebrand's, or that individual, when he was a fetus and growing, or an embryo and growing, some change happened in his von Willebrand protein, or the gene for his von Willebrand protein, which resulted in von Willebrand disease that he then now has the potential to pass on to his children. While it's unusual to have two different genetic diagnoses in a family, given that one of them is known to be so common, it's certainly feasible. And we do have families in which there are more than one bleeding condition that runs either on two different sides or even on the same side. It's possible.
Fantastic. Thank you so much. This one I'm going to read verbatim here, so just bear with me. We could try to paraphrase here. Understanding that blood vessels have collagen and the von Willebrand protein has collagen, are you treating those with Ehlers-Danlos syndrome or hypermobility spectrum disorder and von Willebrand more aggressively or differently? I'll stop there, then there's a second part to the question. So I could read it again if you need me to.
That's okay. So the von Willebrand protein, one of its functions is to bind to the collagen, which is found in the base of the blood vessel itself. So the von Willebrand protein and the collagen are two different proteins, but they interact together. And so if there's a defect in either the way the von Willebrand protein binds to collagen or a defect in the collagen itself, there can result bleeding symptoms. So bleeding disorder meaning, if the defect is on the von Willebrand side, we call it von Willebrand disease. If it's on the collagen side, we call it a collagen defect or an Ehlers-Danlos type defect. There are individuals in whom we suspect both are the case, and this kind of harkens back to our last question about having two different bleeding conditions in the same individual or a same family. Both of these can occur and certainly result in an interplay and enhancing of the symptoms. And really, when it comes to treatment, we target the symptoms that are happening at that time. And so it really depends a little bit on what bleeding symptoms an individual is having, but we're always to some extent aggressive at or trying to be aggressive at managing and minimizing symptoms that an individual is experiencing. The typical treatment for those with collagen disorders is actually the use of things like the DDAVP and the antifibrinolytics. So very much the same treatments that we use for those with von Willebrand disease, and it really just depends on the clinical scenario, what exactly is happening with that individual to help us decide what they might need at that time. But we often will see somewhat more symptoms for an individual who would have both.
Thank you. The second part of the question is, are you Are you or other providers enlisting clinical genetics for diagnosis for the children who are showing obvious hypermobility and more severe bleeding symptoms than expected? This ties into the question that you just answered.
So yes, many of us are utilizing the clinical geneticists as well as the genetic testing that is offered at our individual institutions. And as time moves on, we are still learning more and more about these conditions, both von Willebrand disease and the collagen disorders.
Great, thank you. The last question that we have, and if anyone else has any other questions, you can type them into the question box. Would you, and we know no medical advice is being shared tonight, but the question is, would you suggest Stymate or Amicar for gum bleeding with teeth cleanings?
So the use of these medications and the treatment of bleeding symptoms really would depend how extensive the bleeding is during these procedures. And so the small amount of gum bleeding may be tolerated for an individual, and it really just depends on, and not necessarily treated. However, if there is more extensive bleeding, then there would be a discussion about which medications might be appropriate and might be most useful in the setting of the dental visit.
Great. Thank you so much. If there, I'll give it another 30 seconds or so, but if there's any other questions, feel free to go into the question box. We're a little past 7 o'clock right now, and you can type the question into that box. One more just came up, Dr. Pels. My family has struggled with getting diagnosed with VWD. We are right on the cusp of the levels and have been to several hematologists, not at hemophilia treatment centers, and have been told different things. We don't have any severe bleeding, like paper cuts, but we're concerned that with surgeries, this could be a problem. How do we get properly diagnosed when hematologists are telling us different things with our levels going up and down?
Yeah, this is a big challenge. I had, I could probably have talked about, for half the time about the different things that will affect the levels that you might obtain at any one time. We at this point we really do rely on the levels that we can get during what we feel are the optimal conditions for that individual, combined with family history and the symptoms. But as you mentioned, there may be an individual, particularly a young child, that may not have really had the opportunity to have their blood clotting system fully tested or vetted. They wouldn't have had surgery or any significant traumas, and we worry about the potential for bleeding, as you said, during surgeries. Unfortunately, our technology and our understanding of genetics and the easiest thing would be if we could target, this is the gene to get. If you don't have a mutation, then you're good. If you have a mutation, then we know the answer. I briefly, as an aside, did mention, but didn't really delve into the fact that while there are over 100 different mutations that are known to cause von Willebrand disease, there are patients who clearly have low levels and clearly have symptoms in whom a genetic mutation isn't detected or isn't found on our current technology. So that might mean that there's some sort of mutation within the von Willebrand factor gene itself that for some reason our technology isn't able to detect. And it might mean that there's another gene for another protein that somehow regulates how much von Willebrand factor is in the body at any one time, and we just don't know to test for it yet. that's a long way of saying that genetic testing isn't optimal, even though that would be the easiest answer to the dilemma of having borderline levels. I think what it takes is, seeing a hematologist experienced with von Willebrand disease and having these conversations about, what these levels might mean for your family and based on symptoms, and then really talking about what kinds of things can be done in certain scenarios if there was a real concern about significant bleeding with surgery. Not a perfect answer, but that's what we have right now.
And that seems to be a similar message with another question that came in very similar there. In terms of finding the proper diagnosis and frustration of, do you have the condition, do you not? If there are no other questions, Dr. Pels, is there anything else that you would like to add?
I just want to say that I'm honored to have been able to give one of the inaugural von Willebrand webinars, and I'm happy to continue this relationship with NEHA and hope to serve our patients better and provide education that they're looking for. So thank you.
Well, thank you. We so appreciate this. And for those that did not attend the VWD retreat, this is based on a needs assessment and on session evaluations at our events like Fall Fest and our medical symposium that the New England Hemophilia Association needed, and it was long overdue, a educational event that's solely focused on VWD. So we are committed to holding this again next year. It will be in Portsmouth, New Hampshire. We try to rotate them from Southern New England to Northern New England. But in addition, at all of our events, we try to have at least one or two sessions that is dedicated to VWD. So at Fall Fest, which is coming up November 3rd and 4th, we're going to be talking about emerging therapies. And at the same time, the hemophilia one's going on, VWD will also be going on about emerging therapies. And so, and there is another session specifically about women and bleeding, which will cover many of these issues about specifically VWD and other bleeding disorders. So thank you everyone for joining us this evening. We appreciate you spending your Wednesday night with us. And as a reminder, a copy of this webinar in its entirety will be placed on NEHA's YouTube channel. You will get the link to your email as a registered participant. And please stay tuned. There's going to be several other webinars that we'll be rolling out this year. So thank you again for coming. Thank you so much, Dr. Pels, and have a great night, everyone.